Okay, thanks everybody. Good morning. It's nice to be here with you all today. I'm Kelly McDonald, she, her pronouns. I am the Access Modernization Manager with the Immunization Program. So I work on identifying and trying to solve gaps in immunization access across the state. And I want to take some time this morning to do some kind of big picture looking at the landscape of immunization access in our state, where there are challenges, how those challenges impact providers, and the downstream effect on access. And also help you all see sort of where you fit into this big statewide picture. So I am going to share my screen and give me just a minute here. Oh, what is happening? Um, oh, okay. Is that sharing? Not really sure what I just did. Can you see that, Chris?
Yes, but it's not the whole slide, Kelly.
Yep. Yeah, I'll fix that. I just, and then I'll fix this. Okay, that should be good. All right.
You got it. Yeah.
Okay, great. Thank you. I'm going to go off camera while I present. I'll come back on at the end for questions. And also, if you have questions, during the course of this presentation, please feel free to raise your hand or put it in the chat. And Chris, if you could monitor those and just let me know if I should pause. Great, then
standing by.
We'll do that. And okay. Great. So yes, Kelly McDonald talking about vaccine access and really looking at our finance model and how that impacts access statewide. Next slide. Okay, so I'll give some background, talk about the current state that we're in right now and what we see in some of the data trends, and then also how we're working on this looking forward. So, we all know that along with clean drinking water, vaccines rank among the top public health achievements in modern history. In some ways, they're a victim of their own success, right? We know that millions of vaccine preventable diseases are not contracted each year because of immunizations, and it can be easy to forget how important this intervention is in safeguarding our individual health, the health of our communities, and also our economies, as we saw during COVID. So we'll put vaccines front and center. Today, you'll have your whole day focused on this, which is really exciting. And I'll talk about our programs and particularly in the context of our statewide system. Okay, so our 30-year-old vaccine finance model has been crumbling in recent years. This impacts multiple healthcare systems throughout the state. So immunizing clinics, of course, also pharmacies, hospitals. There's a big impact to our local public health partners and providers, health plans and payers, just really the entire health system. And we know that the cost of inaction means a further erosion in access. And we also know that there are systemic barriers that impact some groups more than others. Missed opportunities create a greater risk of vaccine preventable disease and the need for treatment or missing school or work. But the bottom line is that everyone should be able to get the immunizations that they need. Thinking about equitable access and equitable vaccine access specifically means that every person is able to access vaccine, regardless of socioeconomic status, race, ethnicity, language, geography, insurance status, or citizenship. And most importantly, equity does not just happen. It requires intentional efforts to dismantle the barriers to access and to reach underserved people. OHA's strategic goal is to eliminate health inequities in Oregon by 2030. So this work around vaccine access fits squarely within this goal. Okay, so what does our 30-year-old vaccine finance model look like? It looks like several different programs. So we have different programs that have been designed to improve access for specific populations of people, typically based on their age or their insurance status. The Vaccines for Children program is a federal program that provides vaccine at no cost for children from birth up through their 18th year, so up until they turn 19. And it is for uninsured children, Medicaid eligible Oregon Health Plan, or American Indian Alaska Native children. And roughly about 50% of Oregon's kids qualify for the VFC program. The VFC program was created by Congress in August of 1993. It was a response to a large measles outbreak, tens of thousands of cases of measles, and there were many deaths as well. And looking back over the data, it was apparent that more than half of the infected children had not been immunized, even though many of them had seen a healthcare provider. So they had gone to the doctor for well child or other visits and left without their vaccines. So the program was designed to help improve access for those who were the least likely to be vaccinated at that point. It's important to highlight this because in Oregon, we have measles cases right now, more than we have seen in over the last 30 years. I want to say 33 years or so. So just want to highlight that as well. Our Section 317 program, this is, it actually predates the VFC program. It was the nation's first attempt to fund vaccination efforts for those who couldn't afford them. We use our very limited 317 funds to provide vaccine for uninsured adults. It's important to note that while VFC is a federal entitlement program, meaning that we get enough funding for vaccine for eligible children, Section 317, that program is a discretionary program. So funding is set through an annual appropriations process, and it's not guaranteed from year to year. In fact, our program has been flat for many years, and I will talk more about that later. And then VAP, the Vaccine Access Program, and what we call billable vaccine, that is a state program specific to Oregon, and I will talk more about that coming up. And then others, we have other programs that are temporary programs that pop up to address a specific need. So for a time, we had the Bridge Access Program around providing COVID vaccine for uninsured adults. We've also over decades have had these waves of funding for specific programs, like, for example, following September 11th or H1N1, of course, around COVID response, so that we are able to invest in staffing and infrastructure, create new pathways for immunization access and be innovative, but then those programs end. And so a lot of that work is unsustainable. Okay, so the Vaccine Access Program, as I said, this is a state program unique to Oregon, designed to improve access. It was developed in the early 2000s, as it shows there. At that time, specifically for local public health clinics, so that they could serve all clients who walk through their door, regardless of insurance type. They would be able to get all of that vaccine for those clients from us at the immunization program. So all state supplied vaccine without having to purchase it, have that big upfront outlay of funds to purchase that vaccine. They could order from us and maintain just a single stock of vaccine. And then for those billable clients, that means just those clients who are well insured. The clinics would bill the payer and then pay us back for the cost of the vaccine once they got paid from the payer. So they would keep the administration fee, and pay us back for the cost of the vaccine, but not have that upfront cost. And that worked really well. We later expanded it to other provider types. So most of the federally qualified health centers, FQHCs in Oregon, are enrolled in the Vaccine Access Program today. And we also have some private clinics that serve special populations. So naturopaths, community health clinics, street medicine providers, and small loan providers in rural and frontier areas. Also, providers whose clients include populations such as refugees, students, safety net services, LGBTQ+, et cetera. And the bottom line around the vaccine access program is that funding has not kept pace to sustain this in the way that we would like it to, which I'll talk about in more detail later. Current state. So where are the barriers? Several significant challenges have come up over the last few years that have really threatened the health and sustainability of our vaccine programs, and has added just increased complexity and cost for immunization providers. There are many details to each of these that I don't have time to go into today. This presentation skims the highlights. And this list does not reflect all the challenges. I'm sure others in this virtual meeting space today could add to this list. But the bottom line is that it means an erosion of access points for those in Oregon who want to be vaccinated. I should also say that most of these challenges are not unique to Oregon. So rising vaccine costs, new vaccines that have been added to the immunization schedule, insufficient funding. We have IIS technology needs for our alert immunization registry. I'm sure there will be an alert speaker today who can talk to that. And as I said, just growing complexity to be a provider. I talk about a patchwork, which is how I think of all these different programs that we have to ensure access. So this image really represents the efforts made to ensure that there's immunization coverage for specific groups. So we have different programs for different ages and insurance status, and each one makes a different square on the access quilt. And we just know that, you know, as we try to stretch programs to include more people, particularly when we don't have the funding to do so, that our patchwork gets stressed and it can weaken at the seams. So that's really what we're seeing now. And for many years, we've tried to smooth over the patchwork system, but it is fraying and at the point where we need some changes to our vaccine finance model to better address the issues. And I just want to make one important distinction here, that coverage, immunization coverage, is not the same thing as access. And so in Oregon, with our Medicaid expansion and Oregon Health Plan, we've done a really remarkable job expanding immunization coverage, insurance coverage. But if we don't have enough, or we keep losing immunization providers, then the coverage doesn't matter because we need to have access points. This is just a visual of the program. So you can see in blue our vaccine access program, who all is included there, all of our local public health authority clinics, most of our federally qualified health centers, tribal clinics are enrolled, and then some private clinics serving special populations. And it's over 300 clinics currently enrolled in the vaccine access program, which is almost half. And then we have the other 54 or so % are private VFC only clinics. And there is a separate set of challenges for those clinics that I will get into. It's important to note that this visual does not include immunizing providers who only utilize privately purchased vaccines. So think nearly all pharmacies, and there are some clinics and other immunization providers who aren't enrolled in a state-supplied vaccine program. They purchase all their own vaccine. And then there are clinics that opt out of providing immunizations to their patient population altogether. It's hard for us to have a handle on exactly how many of those there are in the state, but we know that exists as well, and they aren't captured here. Same thing. This is just looking at it by provider type, and based on the provider type or what program they're enrolled to or not, means that it's just it reflects how the vaccine is paid for, where providers get it, and what piece of the patchwork they can access for their patients. Okay, so I mentioned that the vaccine access program is no longer sustainable. And again, that is due to significant vaccine cost increases. We have challenges around certain direct ship frozen vaccines. I won't get into the weeds of that here, but due to some outdated federal systems and processes, we're no longer able to provide certain direct ship frozen vaccines. So those are varicella containing vaccines and Pfizer COVID vaccine. So it just makes it harder for vaccine access program providers. They have to then purchase those specific direct ship vaccines separately, purchase them privately, have, contracts, work with a distributor, the manufacturer, bill for them. They have to code them separately in alert. So those are coded as locally owned instead of B for billable vaccine for our VAP clinics. So again, just adds to the complexity. We have a wait list for enrollment into our program. I think upwards of 30 clinics and pharmacies on that wait list right now, again, because we don't have the funding to either to support staffing to enroll the providers, but also to purchase the vaccine upfront. And since the beginning of this program, it was started, as I said, back in the early 2000s with one-time state funding. We have not had dedicated funding to support the operations internally, but it has just become more difficult to manage. Okay, next slide. This is looking at increased vaccine costs from December of 2005 to, I should have updated that. It should say to December of 2024. And the reason that says December is we publish our billable price list, what we pay for our billable doses of vaccine. We publish that twice a year. So from January to June is one, and then from July through December is the other price list. So looking at the current price list that we're in now, if you just look at one dose each of every vaccine listed on that sheet, it's possible to compare and see the growth and cost. So looking back in December of 2005, just one dose of each vaccine listed on that price list was about $650. Today's price list is closer to $6,000, and it's an increase of almost 800%. Also, I talked about insufficient public health funding that's at the state and the local level. So looking at staffing, we, when back in 99, we had 150 enrolled clinics. We have 650 approximately today. We managed 5 vaccines back in 99 and have 22 routine immunizations that we manage today. And then looking at our vaccine budget and how it's grown exponentially. In 99, our annual vaccine budget was $750,000, and today it is over 117 million. Of course, our population has increased as well. So we had 3.4 million people in Oregon in 99, and today we have over 4.2 million. So, that's more work for clinics. It means more demand, more data in Alert IIS with all the accompanying data quality activities. We have more kids in schools to be reviewed for school required vaccines, more schools to monitor and work with around that program. So we've had a significant increase. I mentioned our Section 317 program. Again, that is for providing vaccine for uninsured adults. You can see in 2014, we had quite a big drop off of the funds that we received for that population, and that has stayed flat since then. These funds are just really critical to ensure access for uninsured adults, including migrant and seasonal workers. It's also what we have available to address urgent public health needs like responding to outbreaks. And the result of the decreased and flat funding is that we have to adjust our formularies. We have to reduce what we can offer, what we can provide for uninsured adults, because it has to, fit within that reduced budget. And so we have a clinical council that meets to make those decisions about what vaccines we will provide and what we won't. What that means on the provider end for those enrolled in the vaccine access program is that you have your Section 317 chart. And so if you have an uninsured adult in your clinic, you have to consult that chart, often read through a lot of little footnotes and different information to figure out what, in fact, they are eligible for under 317 guidelines and what we can provide. I'll just note that there has been a proposed vaccine for adults program at the federal level. This is The idea is to model it after the Vaccines for Children program. This would be specific for uninsured adults with federal funding. It was placed in the Biden administration's budget, and it's very much up in the air whether we will see any action on the VFA program actually passing. There are a lot of variables for that, including, of course, the next election. Okay. Looking at the local level. So this is talking about local public health departments, county health departments. In Oregon, we have a decentralized public health structure. So that means the authority, the local public health authority, resides at the local level, at the county level. And their role is really to assure access to vaccines. There are statutorily required activities around reporting adverse events and around school immunization law and those required activities. We contract, the Oregon Immunization Program contracts with county health departments for those activities. But what we really know is that capacity is very, very different county to county. That could be billing capacity, capacity to provide immunizations, and that these local public health departments are not well funded for this work. We are able to provide some funding. We know that it's not enough for most counties. It does not support or even come close to supporting one FTE. And often the person that's charged with the immunization work is also the CD coordinator or the WIC coordinator, or they're rooming patients, et cetera. They're really split between a lot. In the previous fiscal year, we had 19 counties that received less than $15,000 to do that contracted immunization work. So it really relies on local public health to be creative, to work with partners, to utilize other funding sources where activities can be streamlined. So, for example, there is public health modernization funding that can also be used by local public health to focus on shared goals around communicable disease prevention, immunization work. But local public health is really there as a safety net. And so what happens to local public health when more and more providers opt out of providing vaccines? They typically will refer to local public health. And so sometimes that means that families get trapped in this loop of not being able to access vaccines. Not all counties in Oregon, not all local public health departments offer clinical immunization services. And so sometimes there could be a provider who's not enrolled in any of our programs. They refer VFC eligible kids out to the local public health clinic, and then they too are not providing those vaccines. They may then refer them on somewhere else. This is where we have concerns around our high school exemption rate. I'm sure you'll hear about that today from our school team, and that some of those non-medical exemptions, parents opting their child out of vaccines, could be due to lack of access, that it's harder, in fact, to get those vaccines for their children than to do the work required for a non-medical exemption. Of course, we also have a risk of disease outbreak if there are fewer providers offering vaccines, we have more missed opportunities. That work around disease outbreak investigation and communication will land primarily with local public health, at least in the beginning. And so that is also a potential added burden for them. Looking at COVID commercialization, it's a very interesting juxtaposition of how things were for a period of time and then how things changed as COVID moved into the commercial market and was treated just like all other routine immunizations. So there was funding during the COVID response to remove barriers for both the providers of immunizations and for the public. So there was no patchwork to worry about. You did not have to screen for insurance or collect money. There was no cost for the vaccines or for testing or for therapeutics. And it allowed for a lot of mobile clinics. It allowed for folks to be able to, access immunizations at their local, of course, their pharmacy or their library or place of business or grocery store. So it really centered equity to be able to remove a lot of barriers. Community-based organizations were funded well to ensure culturally and linguistically appropriate materials or events. And looking at how that's changed since then, did I miss a slide? Looking at how that's changed since then, the vaccine was absorbed into the patchwork. So now it's just like other routine vaccines, cost to purchase, you have to navigate billing. We had a different bridge access program for a while for uninsured adults. And I think for, folks in the public, there was just a great period of confusion and reduced access, increased cost, insurance requirements, all of that to navigate is confusing and challenging for all. In terms of equity considerations, the COVID community engagement grants ended. Limited duration positions that were created to work on COVID response and to make sure that there was vaccine available throughout the state were ended, and that infrastructure was mostly no longer supported. So it was a bumpy transition to COVID commercialization. I'll go back here to this slide. This is looking at that first dose COVID vaccination by race ethnicity. This is at the height of vaccine outreach, mobile clinics, funding to support community engagement. And when we were able to scale up our response in a way that took vaccine to people in collaboration with partners and community groups. And we had a goal to vaccinate 80% of adults in communities of color, and we achieved that for the first dose goal for most groups. This is testimony from the Association of Immunization Managers. They work on a lot of policy at the federal level, representing the state immunization programs. Testimony about the short-term funding and emergency funding, and that it would expire, and then immunization programs go back to their near pre-pandemic levels. And they said this is akin to building a fleet of battleships that are sent out to win one battle and then immediately brought back to be scrapped or mothballed. So all that to say, this is really the time to try to sustain and build on improvements that, all those lessons learned from the pandemic and that were made possible with additional funding and a focus on equitable access. Okay. So I mentioned new vaccines. We had several new vaccines in 2022, 2023, all very expensive. And then just navigating coverage requirements can be a barrier for the public and for providers as well. Private plans have 1 calendar year from when the Advisory Committee on Immunization Practices recommends a new vaccine until they have to start covering it without cost sharing. And even then it starts to apply on a rolling basis. It's not like a switch is flipped and it happens on one day. Oops. Let me go back to that for 1 second. But carriers often do start covering earlier. It's often in their best interest to do so, but they're not legally required to do so. And so it just creates this period of time with new vaccines where there's a lot of uncertainty, and coverage could be different depending on the payer until they get all of that settled and into their own systems as well. I talked about the growing complexity in all of the new vaccines. This is the immunization schedule back in 1995, not too long after the VFC program started. So you can see there were 5 vaccines there. And then this is it today. There's a separate schedule for adults. There are 8 pages of footnotes to this schedule, a different catch-up schedule for kids who are behind. And of course, it can, for clinicians, take a longer time to work through these visits with parents who might have, or other patients who might have questions, who might have seen something online, have hesitancy, or just trying to figure out what's true and what's not true around vaccines. I won't really go too far into the weeds here, but these are just some of the many variables that clinics need to consider around their workflow, eligibility coding for each dose of vaccine, billing, how to bill, what to bill, ordering vaccine, purchasing for those vaccines that are not included for vaccine access program providers and have to be locally owned. Of course, documenting and then dealing with vaccine hesitancy or questions, dispelling myths, etc. And this slide is intended to look very messy and stressful, and that is because it's just a small reflection of what some clinics need to use to navigate the patchwork of vaccine programs. So coupling this with staffing constraints or new hires who need training, it just makes for a very challenging environment. Other barriers creating access gaps, each one of these could be its own presentation, which, I certainly don't have time to go into today. But the reality is that we need some of these non-traditional providers like hospitals and pharmacies and long-term care facilities and other partners to be involved in ensuring immunization access. That's ideal if we expect to improve access going forward. The settings are really important access points, but there are barriers to VFC enrollment around strict federal and state VFC requirements. They can be burdensome and costly, and they can prevent some providers from joining our program and can result in others leaving the program. For VFC specifically, we see some real barriers for many rural providers or small volume family practice providers, particularly those who serve primarily VFC kids. So for those VFC kids, they're able to get the vaccine at no cost, order that from us. But for their handful of privately insured kids, they have to purchase an entire separate stock of vaccines. And that can be really, really costly, upwards of, depending on the size of the clinic, $20,000 to $60,000 for a large cash outlay for vaccine inventory that sits in the fridge. It could potentially for several months before each dose is administered and then billed. And then, of course, there are concerns about wastage, expiration, et cetera. And then, I just want to call out too that in rural Oregon in particular, there have been pharmacy closures that coincided with the COVID vaccine rollout and then and then we have seen more since then. So of course we had the Bimart closures and we've seen other pharmacies close in the wake of the pandemic. And this impacts many of those Medicare covered adults that are seeking vaccines at their pharmacy. We know that, of course, it also means that then folks are looking to local public health to access vaccines. And it can be very challenging for our local public health partners to contract with Medicare to be able to serve that particular population. And for long-term care facilities, there's just no statewide system to ensure that residents get vaccinated against respiratory illness each year. It's just really a huge gap in access for those who are among our most vulnerable. Okay, let's see. I will move to the next slide. This just is sort of a visual representation in my mind of what a lot of providers or the general public is experiencing when they're trying to get vaccine. This little guy just wants his cheese, but he has to figure out how to get there. And that's not unlike trying to solve access challenges or trying to figure out for providers how to navigate the different programs and requirements and complexity of new vaccines. Providers just want to vaccinate their patients, and patients just want easy, affordable access to disease prevention. And then for OHA, this maze ultimately leaves our hands tied in trying to make vaccines as accessible as possible. So we spend a lot of our time trying to make a broken system work. And with COVID vaccine, that smashed a big chunk of this maze to remove barriers. But then, of course, that was temporary and all those walls came back up. Okay, data trends, and I see I have about 10 minutes left, so I'm going to scoot through the remaining slides pretty quickly. Data trends. So where do people in Oregon get vaccinated? This is looking at 2023 data, doses reported to our Alert IIS system. And so you can see that the vast majority of doses are administered in private practice. 63%, with another almost quarter of doses administered in the pharmacy setting. And of those in the pharmacy setting, most are flu and COVID. There are, of course, some others as well. And then we have our federally qualified health centers and local health departments. I should note that this graphic is all ages. And when you break it down by age, you see things look a little bit differently. I don't have those included in this presentation, but as you know, so for the youngest of clients for children, they are primarily served in their private practice, their medical home, pediatrician, et cetera. And then as folks age, that shifts a lot to pharmacy. So it's a pretty substantial change. This is looking specifically at vaccine access in in frontier versus rural and urban counties. And the orange is highlighting local public health departments. And so you can see in rural and urban counties, local health departments provide a fairly small proportion of vaccines, 2% in urban, 3% in rural. But in frontier counties, of which we have 10 in Oregon, we see a very significant increase. So those counties really are serving as that critical safety net, providing vaccines in what are often vaccine deserts where there are not a lot of other options for folks. The F2HC percentage also increases significantly in frontier counties. You can see that going from 5% in urban, 11% in rural, up to 20% in frontier counties. Looking at our 2-year-old up-to-date rates, just quickly, I'll point out that we had a slow and steady increase in trends for about 10 years until, or for several years leading up to the pandemic. And then in 2022, where you can see that there has been a drop of 3%, that's reflective of the cohort of babies that were born in 2020 when we had really severe disruptions in care. And so we've dropped off. We dropped off to 69% and then to 68% in 2023. 3% may not seem like a significant number, but when you compare it to the gains that we had previously had, steady gains for several years, it is really concerning. And then, of course, there are concerns that our increased complexity and cost to provide immunizations has just made it that much harder to improve these rates and get them back up. This is an older slide, but again, you don't need to read it. I just want to point out, oh, I think I took out, okay, this is the adolescent rate. So I just want to point out two very quick things. One, if you look at the right-hand side, you can see a data trend. This is from 2018 to 2022, and you can see flat or slightly downturned trend there. But what I want to point out is this red highlighted 91%. That's for Tdap, one dose of Tdap. And that is a required vaccine for 7th grade school attendance in Oregon. So you can see how having that school requirement really impacts the rates compared to others that are not required for school. Just wanted to point that out. This is looking at flu vaccine over the course of 1, 2, 3, 4, 5 flu seasons. The blue line was last flu season, and you can see that that we trended below even pre-pandemic, the pre-pandemic season of 19 and 20. When looking at flu vaccine uptake by rarest race and ethnicity, you can see that all of these rates are low, but they're especially low rates and really striking disparities with the American Indian, Alaska Native, Black, and Hispanic or Latinx populations. School immunizations, I won't go into because we will have folks talking about that later. So looking forward, the vision is to reduce barriers for immunization providers of all kinds so that we can increase equitable access to vaccine. So we want people who want to be vaccinated to be able to get vaccinated with relative ease. And we just really need to shore up the foundation to do that. This is a cartoon that I just really like. What if we don't change at all and something magical just happens? It's funny. And it's just important to consider what happens if we actually don't make any changes or if we make very limited changes. So to that end, last year in early January, we held a vaccine finance summit in Portland. It was a day-long in-person event, and we had attendees, well over 160 attendees from across the healthcare system, come together to listen to presentation and panel discussions about these very issues. So what are the challenges for immunization providers? How does that impact access around the state? How does it impact the various sectors of our healthcare system, and what can we do about it? As I said, we had panel discussions, we had a provider panel, we looked at other state models, and we had a panel of payers. We also had breakout discussions and a debrief at the end of the day. And the feedback was really overwhelming that the status quo was no longer sustainable. We needed to make some change. And we had a lot of folks who wanted to be involved in that change. So we formed a multidisciplinary vaccine finance reform steering committee that was tasked with developing a framework for a new model. So how do we take this patchwork and how do we make it vaccine more equitably accessible throughout the state? And how do we reduce barriers for providers? I have 26, that's a 26-member steering committee meeting twice a month. We first had an introductory call in May and then met twice a month, June through September. Yesterday was that steering committee's last meeting, and they will deliver their recommendations to OHA very soon, by the end of this month. And those recommendations would also provide strategy recommendations for introducing any legislative concept or requests that result from the committee's work. So I expect to have more updates about that to share at a future presentation. And that is it. I know I gave you a lot of information, crossing all kinds of different areas of immunization access, and I'm happy to take questions if you have it, and also feel free to reach out to me at any other point to talk through it.